is Allergy Immunotherapy, the Future of Allergy Treatment. So this review was published in the journal Drug Discovery Today in January 2016. And the main author of this paper is Johan Larsson. So Larsson is a molecular biologist, and now he is in the field of allergy immunotherapy and allergen nomenclature. And he was also a main member of the committee that was there to determine the 3D structure of one of the main allergens, which is the birch pollen major allergen. And Broge is a chemist. Now she's in the field of the production of immunotherapy tablets. And Henrik Jacobi is an allergist. So this paper was published in Denmark. Moving on, the important fact that we all have to know is that allergy is considered an epidemic currently. And in this review paper, they mainly focus on respiratory allergic disease, which is again a serious problem. So it is a major health issue in both developed and developing countries. So it's not limited to developing countries, but in developed countries as well, allergies are spreading in higher rates. So this is the most common chronic disease among adolescents and young adults. And there are different respiratory manifestations, while 235 million people are suffering from asthma and hundreds of millions of people are suffering from allergic rhinitis. So when you look at the common symptoms due to these allergies, there are different types of symptoms. So the topmost three are the main respiratory symptoms that are arising due to these allergies. So asthma is one of that. So asthma is a chronic inflammation of the airways, and there will be an airway obstruction and hyperresponsiveness that is caused in the airways. So as a result, the patient needs to inhale artificial bronchodilators so that the patient can properly breathe. So this is an inhaler or a puff, you might know it as a puff. So these contain different artificial substances like corticosteroids that will allow the patient to breathe properly. And rhinitis, as we all might know, we might have our relatives or friends that are suffering from allergic rhinitis. So this is the blocked-noted runny nose, usually accompanied by sneezing or an itchiness in the nose. And conjunctivitis is a symptom that is observed in the eye. So this is the inflammation that is seen in the eyes with the flashing. Flashing is the redness, swelling, watering, and also itching of the eyes. So anaphylaxis, eczema, and urticaria are other symptoms that are usually associated with allergens in the food and also in drugs and so on. So allergy, as they simply put it, it is the systemic immunological disease initiated by priming of an adaptive immune response to common allergens. So this might be a long definition, but to simply put it, there are two types of immune responses in the body. So one is an innate immune response and the other one is an adaptive immune response. So innate immune response is basically, it can be the skin barrier, the mucous membrane, innately you have it. But an adaptive immune response is usually associated with cells and antibodies that are residing in the immune system. So this is an immune response that is launched against common proteins maybe. So these can be normal proteins, harmless substances to other healthy people, but for patients who are predisposed of getting allergies, these are considered as allergens that might be launching an allergic response in the patient. So there are two phases to an allergy. One is the immediate phase, which can happen within minutes of exposure. So this can happen due to release of different chemicals from basophils and mast cells. These are two types of cells in the immune system. So late phase can occur within hours of exposure, and this can happen due to attraction of inflammatory cells like eosinophils, basophils, neutrophils, and macrophages and other mononuclear cells. So this is an inflammatory reaction that can cause the secretion of mucus and constriction of smooth muscles and so on. So currently, there are different treatment methods for these allergic disorders. You might not see allergen avoidance as a treatment method per se, but currently these clinicians, these allergists are advising the patients to avoid the allergens as much as possible. But it is not practical, because if you take a house dust mite allergy, and the common allergen is house dust mites, and house dust mites are ubiquitously found around the homes and every known place in the world generally. So the patient cannot avoid these allergens always. So if he or she were to avoid it, then you might need them to live in an artificial bubble or something. So it is not very practical. And the other one is, when it comes to a country like Sri Lanka, most people might not know they are having allergies. And even if they know they're allergic, the patient might not know what allergen they are exactly allergic to. So allergen avoidance is not always practical. And also, the pharmacotherapeutic products are the main and the most popular treatment methods for these allergies. But here again, the pharmacotherapeutic products might not provide the permanent relief for these allergies for the patient. So if you are getting an allergic reaction, the allergists might prescribe these pharmacotherapeutic products, but the patient needs to get it over and over, probably for the rest of his or her life. So allergy immunotherapy in this case might be the best candidate, which can provide the permanent relief that I was talking about, because it is a treatment method that can target allergic disease by affecting the basic immunological mechanism, so which is the root of this disease. And this can induce something called an immune tolerance. So I will talk about this term later. So this tolerance, the principle of tolerance, can actually prevent the progression of the disease by decreasing the aggravation of symptoms, and also it can prevent new allergies as well. So allergic disease, as I mentioned before, the prevalence of allergic disease is skyrocketing these days. And the most common manifestation of these diseases is rhinoconjunctivitis. So rhinoconjunctivitis is basically the combination of the symptoms of rhinitis and conjunctivitis. So since this paper was symptoms, so in the European continent, from that telephone survey they have done, they found out 29% of the general population are having symptoms of rhinoconjunctivitis. So you cannot always say these statistics are always true, but this can give us a general idea as to how. So even in Italy, there's about 17% who are suffering from rhinoconjunctivitis. So it might bring up to an average of 23%. So they're talking about European continent in this case, but if you apply it to the whole world, there might be a risk of having an increased rate of allergies currently. So also, and a rather interesting and a rather serious remark was made by European Academy of Allergy and Immunology, that within few decades, more than half of the European population will have some type of allergy. So even though this applies to the European population, there is a high chance that this in a few differences might be applied to the whole world. So this is very serious, and you should not take allergies for granted. And that is the important point of the introduction of this article. So moving on. Allergy, they're stating allergy is a chronic disease. Why? They have analyzed the general population, and they have done a cross-sectional study for the general population in this Copenhagen allergy study, where they analyzed the same study group for a period of time repeatedly. So what they have found out was that there is an increase in the prevalence of allergy in younger groups, but there was no change in the older groups. But one might argue that the older generation might be outgrowing these allergies, but it is not the case, because after this analysis, after 8 years of analyzing the same study group repeatedly, 85 of the patients were still symptomatic. So this proves that allergy is a chronic disease, and it might last for a lifetime in a particular individual. So again, this proves how serious these allergies are, and you should not take it lightly. So there are different expression routes and different allergies known to people, respiratory, food, and also allergies due to insect venom. And you might even know other allergy types as well. So they have mainly focused on this part, which is the respiratory allergy. So respiratory allergies might arise due to inhalation of airborne particles with allergen molecules. So these allergens can go and land on the airway mucosa, leading to different allergic symptoms such as asthma or rhinitis in this case. So they also state that the symptoms might vary according to different routes of exposure. So as an example, if the allergen is a food allergen and you ingest a food allergen, there might be symptoms arising mainly in the gastrointestinal tract. But when it comes to a respiratory allergen, there will be different symptoms arising in the airways or in the airways. So these symptoms can manifest in eyes, nose, lungs, skin, or the GI tract. And also, these symptoms can sometimes arise from multiple organs at the same time. So they also state that the expression of these allergies can change with time. So change in this sense, most of the time, the expression of these allergies can increase in patients most of the time. So when you look at the routes of exposure, there are different routes: inhalation, injection, and skin contact. And there are different symptoms due to these allergies: conjunctivitis, rhinitis, asthma, urticaria, atopic dermatitis, angioedema, and the most serious one of it all, anaphylaxis. Anaphylaxis is a very serious condition because it can occur at any time spontaneously in the patients. So the main drawback of it is that the patient might even have the risk of getting killed. So unless the patient is treated in an emergency treated unit immediately, this might accompany with an allergic shock, and there will be a drop in the blood pressure, and it might be life-threatening for the patient if it's not treated properly. So if I were to give some pictures of these symptoms, this is urticaria, and you call it hives, where you can see red color itchy patches on the skin. And atopic dermatitis is also a skin disease which can form as a pustular manner or as a dry leathery patch on the skin. This is also an itchy patch. And angioedema is basically the leakage of vascular fluid to the topmost layers of the skin. So you can see various swellings in the face or around the lips. So this is commonly seen when a patient is having a food allergy. And these are the main symptoms. So allergic march is a phenomenon. So this phenomenon is the common progression of allergic disease through age. So if you take this picture, if you imagine this is the picture of this kid growing up gradually. So if this little kid is having eczema, eczema starts to appear during the first few months of his age, of his life, then there will be an appearance of food allergies after about 1 year of age, perhaps. And then these symptoms might be disappeared for a while, but at the age of about 3 years of age, there will be a spontaneous remission and also possible worsening of these cases in the little child. So by 7 years of age, there will be an increased risk of respiratory allergies as well. So what they state here is that all sensitized individuals are likely to develop new allergies. So this is another reason why a particular fixed treatment method should be found to address all these symptoms. And this is an obvious fact, which is allergy is a disease of the immune system, because the main hallmarks of an allergic disease is specificity and memory. So memory is, as an example, if the body encounters a particular allergen or a substance at first, then the body starts developing a memory, and when you get exposed to the same allergen, the body might identify that allergen, and the body might start reacting against it, thinking that it is harmful to the body. So also the disease mechanisms of allergies are concerned with the cells and different chemicals that are residing in the immune system. Therefore, it is obviously a disease of the immune system. So there are different drawbacks. So in the paper, they have discussed many drawbacks. So I tried to concentrate on main drawbacks that you get from these allergies. So the main one is that, as I mentioned before, the symptoms are difficult to be controlled with pharmacotherapeutic products. So as an example, patients who are suffering from rhinoconjunctivitis are prescribed with antihistamines or nasal corticosteroids, and patients who are having allergic asthma will be prescribed with bronchodilators and corticosteroids. So when you inhale these products, then if it's an asthmatic, then there will be an ease in breathing for the patient, because an asthmatic cannot breathe properly unless you artificially provide the expansion of these airways so that air will be taken in easily. But the thing here is, although you get reduced symptoms, you might need to use these products for a long time. I mean, for maybe daily, so that you are having the decreased symptoms of these conditions. So here, all the symptoms are reduced, the allergy is not properly addressed, and therefore the disease progression is not prevented. The other one is, as I said, anaphylaxis is a very serious condition, and it is very spontaneous. You might not know when you're getting an anaphylactic reaction and when you should be rushed to the hospital. So it is a very severe disease in some patients. Not just anaphylaxis, a patient who is having acute asthma and other allergic disorders might also be having these in severe conditions in some patients. So another one is that obviously these allergies might affect the quality of life of the patient. So one might wonder what is serious about this. There are more serious conditions in people. Allergies. It is a simple thing. You need to get an EpiPen or just antihistamine, so you will be all good. But it really affects the quality of life of an individual. So if you take a small child who is maybe an athlete, and if he or she is suffering from asthma, then before every sports meet, if he or she has to get an inhaler, then the person might get all these uh, dysfunctioning in the social life, physical life, and as well as in the mental health. So there will also be sleep disturbances and also the impairments in the professional life as well. As similar to the personal life of the patient, the society is also affected, maybe indirectly, because it is a burden to the society when the society has to provide medical care for these huge amounts of patients who are suffering from these allergies, and it might come at direct costs where they use the resources and all the healthcare system facilities in the society, and also it might come at an indirect cost where the reduced performance of an employee might affect the workplace or even the school. So allergy immunotherapy might be the biggest candidate to address all these drawbacks. So it is the process of administration of an allergen to affect the basic immunological mechanisms to induce allergen-specific immunological tolerance. So the tolerance is when the body is seeing that allergen. So if you were allergic to a particular allergen here, like here, before, so after this treatment, the body might not identify this allergen as a harmful substance. So the patient might react to this allergen as similar to a healthy individual. So here, this diagram was not very clear in the paper. Therefore, this is actually the basic immunological mechanism that is happening when you have an allergy. So therefore, I referred another paper where it is simple but clearly explained here. So as an example, imagine if this is a house dust mite allergen. So the allergen enters the body, and there is a cell type called the antigen presenting cell. So in this case, this is a dendritic cell. So this dendritic cell can encounter this allergen, then process it, and these parts of these allergens will be presented to another cell type called a T cell. So this T cell, it's a white blood cell, it's a lymphocyte. So here it is a naive T cell which hasn't been proliferated to a more differentiated cell. So here the naive cell will be activated to a more differentiated T helper 2 cell. So the T helper 2 cells in this case are the culprits of starting these allergic reactions. Why? Because they can secrete different chemicals called cytokines, which can trigger these allergic responses. So when the allergen will be presented to here, and these will be differentiated to form T helper 2 cells. So these have the ability of secreting these cytokines. So IL-4 and IL-13 are very important cytokines in these allergic reactions. So these cytokines will actually activate another cell type called the B cells, which is also naive at first. But when they get activated, they have the ability of secreting different types of antibodies. So IgE antibodies are the main antibodies that are involved in bringing out these allergic symptoms. So this is an IgE antibody in this case. So these antibodies, first, I would like to explain a small part. So when an allergen is taken up naturally into the body, the amount of allergen generally presented to the body in natural means is very low. But this low amount can result in the stimulation of an allergic response to bring about all these symptoms within minutes probably. So they have used this principle in modifying this treatment, allergy immunotherapy, which will be explained later. So these IgE antibodies, when produced, they can go and localize on different cell types. So if you check here, there are two different cell types, a mast cell or a basophil. So they can go and bind to this small fragment, and as a result, so during the next or the subsequent exposure to the same allergen, you can see this allergen is similar to the allergen here. So if you get exposed to the same allergen, and the allergen can bind to these antibodies, and then as a result, different chemicals that are stored inside these cells will be released to outside. So these chemicals are the substances that are responsible to bringing out these allergic symptoms in patients. So it might bind to these antibodies, like it can be a bridging of these antibodies, as you can see from here. Then as a result, there will be different chemical reactions occurring in the cell walls, occurring in these regions, which will release these substances to outside. So there are different types of chemicals. There can be vasoactive amines, such as histamines, lipid mediators, like prostaglandins and leukotrienes, chemokines, as well as cytokines. So this is actually the late phase of allergic reaction, which is inflammation, as I mentioned before. So we might need to know that there are different cell types involved here. These are the inflammatory cells involved, eosinophils, mast cells, basophils, and so on. And T helper 2 cells are the main culprits that are responsible for these inflammatory reactions again. And also, this is why you get these various symptoms like apoptosis, or the cell death of the bronchial epithelial cells, different mucus secretions, and these are arising due to these stimulations occurring here. So moving on to the process of immunotherapy. So what is happening in this allergy immunotherapeutic method? So as I mentioned before, when the body is exposed to a particular allergen naturally, the amount of allergens that is entering the body is low. But this low amount can trigger an allergic response. But here they have changed this principle a bit, where they actually administer the same allergen that this patient is allergic to in gradually increasing amounts to the body. So at one point, one dose might be about 100 times bigger than the maximal yearly intake through a natural exposure. So therefore, the body might be confused, and then as a result, the quantitative difference and also probably a different route of entry will induce an immune tolerance, where the body might ignore these allergens, thinking they are harmless. So this is the principle that is happening in the immunotherapy, and this is achieved in two main ways. One is through immune deviation. So as I said before, I said T helper 2 cells are the main culprits that can bring about these allergic responses. So one way this is achieved is when the allergens will be administered in higher doses into the body. Then instead of forming T helper 2 cells, T helper 1, it's another type of T helper cell. So T helper 1 cells will be formed, will be stimulated, and these cells will produce a certain cytokine called IFN gamma. So this IFN gamma has the ability of stimulating B cells. B cells are the ones that can secrete antibodies in the body. So they can stimulate the B cells to form IgG antibodies instead of IgE. So I hope you might remember IgE is the main type of antibodies involved in these type 1 or immediate hypersensitivity reactions. So in this picture, if they have tried to put it simply, so if the red color, these are the antibodies, these are the Ig antibodies, the red ones. So as a result of this stimulation by IFN gamma, instead of forming the red color IgE antibodies, the B cells will be differentiated so that the B cells can produce IgG antibodies as a result. So here, IgG antibodies thus produced are also specific to this particular allergen, but the case here is these IgG antibodies cannot go and localize on the cell types that I mentioned before, so that there will not be any release of these chemical substances that are responsible for these allergic reactions. Therefore, the symptoms will be decreased in the patients. So there might not be enough allergens to bind to these IgE antibodies. So as a result, allergic disease will be clearly addressed here. Another way of achieving the immune tolerance is that by induction of regulatory T cells, or you call it Treg cells. So the Treg cells have the ability of producing two types of cytokines, IL-10 and TGF-beta. So these cytokines have the ability to suppress the T helper 2 response. Here again, this is the main culprit here. So they can suppress the T helper 2 responses by secreting more IgG and IgA antibodies. So these antibodies can basically block the allergen presentation to these T helper 2 cells in the first place. So therefore, allergic symptoms might be decreased. So there are different modes of treatment using these allergy immunotherapy methods. One is subcutaneous immunotherapy, sublingual immunotherapy or slit tablets, and slit drops. So the first one is subcutaneous immunotherapy, which is actually happening in the form of subcutaneous injections. So the treatment method, the treatment regimen involves two main phases. The first one is the initial phase is the updosing phase, and followed by the maintenance phase. So in the updosing phase, what they do is they administer increasing doses of a particular allergen in the form of an injection to build the tolerance I was talking about, and they address the patient's sensitivity. So they administer it till it reaches a maximum tolerated dose or a maximum dose that is recommended. So when whatever it is reached first will be maintained in the next phase, which is the maintenance phase. So this will be maintained at an optimum dose, and it might go on for sometimes for a few years. But the thing here is, the important thing that should be remembered is, since injections will be administered to the body directly, all the injections should be directed by the doctor or an allergist at the surgery room with all the necessary equipment to prevent severe or life-threatening conditions due to the induction of allergies or anaphylaxis. And also here in these injections, what they have included is, they have included adjuvants. You might know from the COVID terms and all, there are substances called adjuvants. And in this case, these adjuvants, such as aluminum hydroxide, these can complex with the allergen that is included in these immunotherapy products, so that the allergen might be released into the body in decreasing amounts rather than a huge surge into the body. They might be released to the body in small amounts, and this might not lead to a severe or a life-threatening condition. So there are another method is sublingual immunotherapy or SLIT. So this is basically administered under the tongue. So there are two forms mainly, SLIT tablets and SLIT drops. So SLIT tablets are currently considered as safe immunotherapy products. So these are fast dissolving tablets that is safe to use at home. And there are other types of immunotherapy as well, but they have not discussed about them in this paper. There can be epicutaneous immunotherapy, oral immunotherapy, and so on. And they focus mainly on sublingual and subcutaneous immunotherapy in this review paper. So you might be wondering what an allergen is. Some might be wondering. So allergen can be most of the time a protein. So this is an antigen, and these molecules can elicit an IgE response in the patients who are genetically predisposed of getting allergies. So the different patients are having unique sensitization patterns to these molecules, the allergen molecules, and they might produce different IgE antibodies that are specific to these allergens. And there are different allergen products that are marketed, and these are manufactured by aqueous extraction of different allergenic sources. These can be natural sources such as house dust mite cultures, pollen, animal dander, and also insect venom. So before anything, these products, since these are these are products that will be released to the general public to purchase, right? So these products should be standardized before manufacturing, because these are natural compounds that might vary in composition. They can use different references and control extracts, so they can achieve a uniform composition with regards to the complicity of the extract, content of the major allergen, as well as the potency of IgE binding. So are these compositions of these products always the same? No. Why? Because different manufacturers use different raw materials and products and standardization processes. And why they cannot fix to a particular standard is that different patients might react to different allergens in very different ways. So currently, standardization has become a problem for these immunotherapeutic products because they are different in composition, IgE binding potency, and so on. So there are no fixed international standards for these products, and also the products from different manufacturers might sometimes work differently on patients. So as a result, the clinical results might also vary from one allergen to another. And therefore, the product should be chosen by the allergist according to the highest level of evidence of safety, efficacy, as well as reproducibility. So clinical documentation is very important when you legalize or when you release a particular medical treatment to the world, or some clinical test. So this is basically the creation of a digital or an analog record with all the details regarding a medical treatment, medical trial, or a clinical test. So there are various trials that have reported the efficacy of allergy immunotherapy, but unfortunately, they have not fulfilled the ICH criteria. So these are for measuring a particular safety of a therapeutic confirmatory trials. So, but in this case, recently, the slit or sublingual immunotherapy tablets are currently documented in different clinical development programs. And up to this date, these are the best documented immunotherapy products out of all the immunotherapy products known. So here, from here, subcutaneous immunotherapy, they have done a large trial that they recruited patients with grass pollen allergy, grass pollen induced allergic rhinitis, and there was a reduction in symptoms and there was an improvement of the quality of life. Similarly, slit drops or sublingual immunotherapy drops, the efficacy of these drops are quite similar to that of the subcutaneous immunotherapy, and they have done some studies that showed a reduction in symptoms in patients with allergic rhinoconjunctivitis. So out of all, the best documented immunotherapy products on the market are the slit tablets, and these are currently the only products that are developed to meet standards for documentation in the USA and also in Europe. So, as I mentioned, some drawbacks of having allergies in the initial slides, there are benefits of getting benefits of these allergy immunotherapy treatments. So, one is that it can improve the quality of life of the patients. So, they have used this index, the Rhinoconjunctivitis Quality of Life Questionnaire. So, this is a standard index. So after some large trials by using SLIT tablets, they have proved that there is a statistically significant improvement of this index among the patients with grass pollen allergy. Also, another study have shown that there is an improvement in the quality of life of patients by using subcutaneous immunotherapeutic products. And the other main benefit is that it is cost effective. So one might argue, how can this be cost effective if the patient needs to get all these immunotherapy products for a long time? But there might be cost effective. Why they say this is because in one study that was done in Sweden, the cost of loss of productivity due to these rhinitis conditions is about 2.7 billion euros, and it's not just limited to Sweden, it can apply to the world as well. So when you get pharmacotherapeutic products, when you rush to the emergency treatment you need due to these allergies, there might be a high societal cost. And but in this case, allergy immunotherapy, as I said, they will bring about an immunological tolerance that can last for many years. And also these products can be manufactured in a way these are cost effective for the patient. So looking at the state of the art, so they basically talk about the allergy immunotherapy tablets because these are well documented, and also it is comparatively safer. So there are different phases in a clinical development program. So the first phase is the safety and tolerability study. The second phase is dose finding study. And also the third phase is efficacy and safety study. So all these studies are double blinded and placebo controlled. So there is no bias occurring anywhere. So currently there are three main products that are developed according to the requirements of this authorization. So one is the SQ grass SLIT tablet, which is produced by a freeze-dried formulation of grass pollen extract of Phleum pratense. And another one is ragweed SLIT tablet, which is developed to treat ragweed pollen allergy. And the third one is 5-grass SLIT tablet, which is a multi-particulate tablet produced using 5 grass species and using the pollen of those 5 grass species. And the important thing is the disease modification. So the disease modification is actually the beneficial outcome due to treatments that affect the underlying pathophysiology of diseases. And what they have done was they did a long-term trial with this SQ grass SLIT tablet, as I mentioned. So they did it for 3 seasons or 3 years. As you can see from the diagram, they have administered this SLIT tablet to the patients for 3 years. And following this was a 2-year or a 2-season follow-up period. So what they have observed it was they used a placebo for a certain patient group, and also for another patient group they used this SLIT tablet, and they observed there was reduction of symptoms compared to the placebo. As you can see from these bars, there was a reduction of symptoms, and during the follow-up period, so at the end of the treatment, the patients were not given any treatment here after 2 years. So here also this reduction was maintained for those 2 years as well. You can see from here. So therefore, this SLIT tablet was approved by European authorities. And another way they address the disease modification is via prevention. So the prevention of these allergies are happening in 3 main levels: primary prevention, secondary prevention, and tertiary prevention. So in the primary prevention, what is happening is the first immunological sensitization will be prevented. So here, this means that if someone is genetically predisposed of getting an allergy, the patient will be treated so that there will be no immunological sensitization for a particular allergen in the individuals. So this can prevent the priming of the immune system by stopping IgE development against particular allergens. In the secondary prevention, these treatment methods can be used for already sensitized individuals. So what they do is they prevent the clinical symptoms in already sensitized individuals. So this can be achieved in two ways. One is that it can prevent progression of new sensitization. So as an example, if a patient is having grass pollen allergy at first, developing it to a birch pollen. So this is a different type of pollen. So getting new types of allergies will be prevented here. Another way how this is achieved is by preventing progression of new clinical manifestations. So if a patient is allergic to house dust mites, and if they already have the condition of rhinoconjunctivitis, this will not be worsened to get asthma. And this will be stopped at this point without just worsening it to another symptom like asthma. The tertiary prevention is actually preventing an attack of illness in a patient who is already having these allergic symptoms. So asthma will not worsen to acute asthma in this case, and this will be prevented at this stage, and it will be a relief for the patient. So there are ongoing prevention studies known. So one such thing is mite allergy prevention study, or MAPS. This is actually a primary prevention study where they try to prevent the initial sensitization of a particular patient to a particular allergen. So they use a group of children with a high risk of getting these allergies, and they were treated with slip drops, sublingual immunotherapy drops containing house dust mite allergens, and they administer it twice daily for about a year, and they regularly assess them at 3-month intervals. The second one is the GPAC study, which has been terminated after the pilot phase. Why? Because they could not observe any difference in the IgE-IgG ratio when they compared it with the placebo groups. But the secondary prevention methods are showing much promise. So one trial is the PAT trial. So they used this subcutaneous immunotherapy method, and they tried to prevent the developing of asthma in children who are already suffering from rhinoconjunctivitis. And what they did was they administer these immunotherapy products, and they monitor them for 10 years to check asthma development. So this will be explained in the next slide. The other trial is the GAP trial, which is also a large asthma prevention trial. But in this case, they used the SQ grass slip tablet, and they checked the development, the presence of the development of asthma in children who are already having rhinoconjunctivitis. So PAT trial, as I said before, they used these injections, and they recorded these asthma incidents. They checked if there is an incidence of asthma at 3, 5, and 10-year intervals. So this is the treatment period. And after this, the treatment will be terminated, and they will be monitored during the follow-up period ranging from 3, 5, and 10 years. So what they have observed was they have almost 45% reduced the development in asthma than the control group. So the difference was also maintained during the follow-up period after 10 years as well. So here you can see the allergy immunotherapy is showing much promise, and it might be a good candidate to address these allergic conditions. So looking at the future of AIT or allergy immunotherapy, people argue if these are carrying the risk of anaphylaxis or carrying high severe risks in patients, even though they are getting treated. Yes. So there is actually a need to try safe and more effective AIT strategies, especially for patients who are suffering from asthma, atopic dermatitis, and food allergy. So then now they can actually introduce some novel immunotherapeutic approaches that can improve the immunogenicity of this immunotherapeutic method without increasing the allergenicity. So one way is that they have used novel adjuvants to increase the safety and the tolerability of these allergenic products containing in these immunotherapeutic products. And also they clone the allergenic proteins with the use of recombinant DNA technologies. So this might be used in the production of vaccines. And another one is they use peptide fragments that are homologous to T cell epitopes. So this is the T cell epitope is the epitopes are in the are structures that are present on the allergen proteins. So these are specific for these T cells. And what they can do is, instead of generating the whole allergenic protein, they use small peptide fragments which are too small to bind to the IG antibodies. So when a particular allergen is bound to IG antibodies, only you get these allergic reactions. But in this case, these peptide fragments are too small to bind to this IgE, but they can induce what I was talking about, which is the immunologic tolerance in the patients. Another way is that modifying these allergens, the recombinant allergens in vitro, to create hypoallergenic molecules. So these molecules are not able to generate an allergic response. Therefore, the risk of anaphylaxis will be decreased, and they have a reduced reactivity with IgE. So all these slides were talking about the aspect of these allergies and the treatment when you look at it in the perspective of a broad perspective. But when you take it to a Sri Lankan perspective, there are, to be honest, there are less numbers of studies that are carried out in our country regarding this prevalence of these allergies. But late Professor Anuraveera Singha is one pioneer who worked really hard in this field, and this is one study that was conducted by him. So it is a cross-sectional study to find out different patterns of allergy among 6,085 patients who were attending the outpatient department at the Ragamat Teaching Hospital. And out of those patients, 537 patients out of this number were diagnosed as having an allergic disease. So 66% of this number fell in the range of age 12 to 60 years, and 22% belonged under 12 years of age, and 12% belonged in the range above 60 years of age. So to put it like 35% of people were suffering from asthma out of this number, and 22% suffering from rhinitis, 15 eczema, 12 urticaria. So by looking at the statistics, you can also say that in Sri Lanka, it is not something that you should take lightly. Allergies are very common. So this study was done in 2007. So according to different papers that was published regarding allergies, it is very possible that these numbers might be, these percentages might be very high when it comes to 2022. So this is why you should address all these allergies in a effective manner, in a permanent manner, so that there will be no disease progression in the patients. So this is the end of my presentation, and if you have questions, you can go on. Thank you very much.
Thank you, Senuri, for that informative presentation, and you have tried your best to make it very simple, and I hope the non-immunological immunology people have understood what you talked about, and I hope they will benefit. And we can now open this paper for discussion. So you can post your questions in the chat box, or else you can ask the questions directly from Senuri. Senuri, to start with, can I ask
Yes,
a question? So, like now, what are the chances of getting those treatments you mentioned?
Yes, ma'am.
In Sri Lanka?
Yes, madam. Currently, since these are still under clinical trial when it comes to a global perspective, it is still not introduced yet to our country. But in the future, there is a high possibility of introducing these treatment methods if they reach a particular safe level. Using these clinical trials, there is a high possibility in the near future that these will be introduced to our country as well, madam.
And I think several products are getting FDA approval soon, right?
Yes, madam. Since my research was done in the allergy immunology unit in Javadanapura, so when I asked them, they said they still don't have these treatment methods here in Sri Lanka, but in the meantime, they will try to introduce to them to our country as well, madam.
Okay. And another question. So,
Yes, ma'am.
what are the chances of relapse after getting this treatment? Have you come across any of the research?
Yes, madam. It says that the protection, the tolerance that is brought about in these treatment methods will last for a few years, but I have not come across main articles talking about a relapse. But this effect might last for a long time, madam.
Okay, thank you, Senri. Any other questions from the audience?
Senuri, it's Vihanga here.
Yes, exactly.
Yeah. I'm just asking a very general question. Like after this COVID-19 vaccination, we happen to see some new allergies in society. Like for example, like people who were not allergic to prawns before became allergic after getting the COVID vaccine. So, I mean, I'm just asking your opinion. Is there any connection between these two? Like any cause of the vaccine to get new allergies?
Getting new allergies, it's like this. As I said, my research was mainly focused in the immunologic allergy clinic in the University of Sri Jagannathapura Medical Faculty. So there also I observed. I cannot particularly say this is due to this COVID vaccine, but there were certain instances where there were patients who were reporting to this clinic stating that they have new allergies, they have rashes, and so on after getting this injection. But but to confirm that, we need more published work. So we cannot just say from our point of view that you might get allergies due to this. So what I generally observed was that there were instances, and they complained that they had they didn't have this before, but they are now having these allergic episodes. But as a student, I cannot particularly say this is due to that Vihanga. So for that, we need to have more identified, more published cases here. So I hope I gave a good answer for that.
Yes.
Okay,
Thank you.
Senuri, it's Sadhani here. I have a small question as well.
Yes, Sadhani.
We've learned about this personified medicine, or the people the medication is personalized according to the genetic build-up of the patient.
Yes.
So what do you think, could this allergy immunotherapy would be developed to that kind of level, and how advantageous that could be in your opinion?
Yes, as I said in my presentation also, the way that a patient reacts to a particular allergen might be different from patient to patient. So therefore, that is one of the main reasons that they cannot standardize a particular composition of these allergy immunotherapy products, because the patient might react in different ways. So as my opinion, so let's take Sri Lanka for an example. So in our country, the sources of different allergens might be different according to different species of, let's say, allergenic sources, such as house dust mites or even fruits and vegetables. The species that are found in our country might be different from that of the temperate regions. So therefore, I feel for each of these allergens, if a country can produce different products, standard products using these allergens, it might be good. And also, it states that when you treat a particular person, the patient might also have an opinion, and the clinician can also decide on which product to use. So as you said, it is basically a method of personalized treatment, right? So the only problem is that they do not have a particular fixed standard for this, and that's why these clinical trials are still happening to find a solution for this. So as I feel, in my opinion, you can personalize this. So this can allow the allergist to treat this a particular allergy in a patient effectively if it is personalized according to the patient. How it is done is not very clear for me, but I think it can happen in the future.
Thank you, Senuri. Thank you.
Okay.
Senuri, there's another question in the chat box.
Yes, madam.
I would like to know if any person is having an allergy, it can be recognized only after that person exposed to that allergen? Is there any technology that can be detected earlier?
Yes, it can be. So sometimes, so there are different methods that can diagnose these allergies. So one thing is they can use different. They can use a panel of allergens, and they can check. Use that the panel basically has different allergen extracts. So as an example, let's say aspergillus, they have an extract, they have vials of aspergillus allergen extracts, and it is a large panel, so the patient can be tested. So they use these tests called the skin prick tests, and they can be tested, and they if there is a particular reaction occurring on the skin, so that is a main indication that that patient might be allergic to that. And another so this is actually the gold standard, but in other case, in vitro, if you want to analyze it, there are other different methods like immunocap, which can actually measure the amount of antibodies, ig antibodies in your body, and that might lead to that might lead to a clear identification of having these allergies. So as an example, if you take me, so I didn't know I was allergic to red meat before, but when my blood sample was analyzed by the clinic, they said that I might be allergic to red meat as well, because the specific IgE antibodies in my body against the red meat allergens were higher than the threshold value. So you can use those diagnostic methods to identify if you're allergic to a particular substance or not. Yeah, that is the answer that I can give for that.
Do we have any more questions?
Senuri, just to say that, as usual, it was a very nice presentation.
Thank you, madam.
I also have been going behind Chandima asking for immunotherapy for my son. There was a time when he said that they are going to import that, right? But I think now up to date, I don't know, maybe it's expensive. I don't know what it is. So actually, just to say that we are waiting for that. Because allergies, I don't think people who don't have allergies, I don't think the impact of allergies will be known. But when you have someone at home, or if you yourself are allergic or atopic, then you know what a miserable life it can be.
Yes.
So yes, so I think this is kind of epidemic, and as you and I both know, I became allergic to prawns in my 50s. I could eat prawns up until then, but suddenly it triggered off. I have one question. You said you are allergic to red meat.
Yes, madam.
You know that before? Do you eat red meat or not?
Madam, yes, madam, I ate pork before, but like I was feeling a bit itchy after eating, but I didn't know it was an allergy. But after they said that I might be allergic, I stopped eating red meat, madam.
Yeah, okay.
So I thought it might get worsened by time.
Yeah.
So yes, madam.
Yeah, no, my only fervent wish is that I don't know. Someday soon we will have immunotherapy in this country.
Yes,
That will service a lot of people. Right. Thank you. All the best.
Thank you very much, madam.
Do we have more questions? We are actually running out of time, but if there are questions, we can take up to one more question, one or two questions. In the absence of, there's something on the chat. Okay, no. Thank you for the answers. The previous person who asked the question has thanked you, Senuri. So, in the absence of any more questions, let us now conclude this presentation session. So, I will invite Dr. Maheshi Mapalamage to officially deliver the thank you speech. Maheshi.
Thank you, Dr. Sachini, and thank you very much, Senuri, for that excellent presentation and for accepting our invitation in such a short notice. I think being a very young scientist who just completed the undergraduate degree, you did a magnificent job in presenting this paper. Yeah, and I also want to emphasize the fact that, like Dr. Sachini said in the initial stage of this session, because one of our main aims in this journal club is to have not only having multidisciplinary various presentations, but also to have multidisciplinary speakers, including academics, non-academics, postgraduate students, undergraduate students, likewise. But initially, up to now, what we had was mostly the academics and senior academics and early career academics. And Senuri, you have opened officially opened this platform to our young academic staff members and also for students as well. So thank you very much for that initiative, Senuri.
Thank you.
And I would also like to thank Professor Sampath Senaviratne and Dr. Sachini, especially for working immensely organizing this event by making flyers and Zoom links and everything. Thank you very much, Sachini. And also I would like to thank the card chair, Senior Professor Preeti Udagama. She's the head of our department of Zoology and Environment Sciences, because she's always enthusiastic with these the presentations, and she's always encouraging us to have this with organizing these events. So thank you very much, madam. And finally, thanks a lot for our students and also the audience for making this event very interactive, as always. So thank you very much. And thanks again, Senuri, for your courageous effort in presenting on this platform. And we like to invite all the students and not only students, one who are interested in science and also who are interested in improving your presentation skills. I think this is a really good platform for you all. So if you are interested, you can always talk to us. We can arrange something for you to present a journal, your paper, or something interesting for you as well. So with that note, I would like to thank everyone and have a nice day.